had his adenoids removed at 6, and they regrew. They were bigger than the first time. So when we met him at 9, we had to revisit the ENT, who took his adenoids out when he was 6 years old, only to find they were bigger than the first time. So those were removed again. We had to get him to the myofunctional therapist. The myofunctional therapist worked with him for the better part of a year. And after about 4 to 6 weeks, then the revision, lingual frenum revision as well. So yeah, he had a pretty comprehensive collaborative care approach.
Awesome. And was myofunctional therapy used for all of the 3 patients you showed earlier?
Myofunctional therapy, yes. The first 2 more significantly with the lingual frenum revisions. The third patient did very little, and I worked with him myself. We did some basic exercises. So when I talk about myofunctional therapy, there I do a little bit. I like to say that when it comes to myofunctional therapy, I'm playing checkers and the myofunctional community is playing chess. So I do very little of that in my own office, but I couldn't inspire that gentleman to go for the full myofunctional therapy routine, which he should have done. Meanwhile, I gave him about 5, maybe 6 exercises that he could do regularly. And then, that in his case, everything worked out very nicely. But I did not have him go to a myofunctional therapist. I ended up doing a few of the exercises with our office.
Great. Dr. Stewart, are you with us now?
Yes, I'm here.
Okay, terrific. I know you wanted to say a few words and kick this off. I just don't want to waste any time.
Yeah. Well, thank you. Welcome, everybody. And Dr. Ben, thank you so much for being here. Our alumni are exceptional people, exceptional dentists, and they need to hear your message because this has been life-changing in my office. And I want them to learn this too. As we're talking earlier before we started, we're all trained to, stabilize joints and get the teeth in great occlusion. But as our practice has evolved, I'm talking personally, we're looking at the teeth and TMJ last because the development of the jaw is and getting that airway opened up is so important. Otherwise, everything that we're doing with stabilizing the joints and getting the teeth occluding is, it can be very difficult to do it when you're fighting an airway, if not impossible. So I want our alumni to hear this. Most of our alumni, like we at our practice, probably treat just the opposite. You're 60% children, 40% adult. We're probably either all adult, some of these doctors here, and which my practice was up until about 3 years ago. We started treating children, but we're still at about 60-40. So we're seeing a lot of adults with broken down teeth, really broken down teeth still. And that has to be treated, but still growing the jaws it's like pouring a great foundation for a house. Then you can build a really solid occlusion and with a solid TMJ. So our alumni are very adept at creating beautiful anatomy and tooth form and anterior proprio-guided occlusion, and they're masters at that. But I wanted them to hear your message because this is really where we need to start. As I was telling you earlier, in a golf game, what we do is the putt to put the ball in the hole. Everything else before that needs to be done first. And we're really good putters, all of us here on this webinar, but not everybody is doing the jaw development, or they're cognizant of airway and how important it is. But I wanted them to hear and talk to you, because I would love to these doctors to start delving and jumping into this. And I think your program is a perfect introductory for them to do that, and then to continue to learn more.
Oh, well, thank you very much. Yeah, and we fit together very nicely. Every one of the adults that you mention and see that has a debilitated, set of teeth and or occlusion needs the restorative component as well. It just happens to be dead last in my world. And it doesn't mean we leave decay in there. Obviously there's a lot of common sense involved. When you have endodontic, periodontal, and restorative needs, it may mean putting out all the fires first. So there are root canals that are done along the way. Then there are temporary, whether it's a composite buildup or a beautiful temporary crown, whatever you need along the way to put out some fires, get the decay. The restorative work is finalized after the growth and development stuff. So there are cases like that where you have the full combination of you're going to get some crowns, you're going to get some inlays, you're going to get some onlays, you're going to get some restorative dentistry as well, because you no longer have the anatomy of your teeth thanks to crushing it away. And then, of course, understanding that it got crushed away because you didn't breathe well, that'll go a long way. If you develop enough room for the tongue and a beautiful space to breathe, you'll no longer clench, grind, and destroy the porcelain that we're making. And so what becomes a secondary pleasure is that you can watch your dentistry go through decades without having anything, no chipping, no marks, no wear and tear, nothing. And I don't have my patients wearing night guards. So we abandoned night guards about a decade ago. My patients who go through treatment do not end up in night guards. The most that they wear to sleep is a clear aligner retainer. And that's just to keep, the teeth aligned beautifully so we don't lose the anterior kind of crowded situation by relapse.
Yeah, it's so very important. Lauren, how were we going to have this like an open forum for our doctors?
Yeah, so I think since there's so many, probably the easiest way to do is just to use the chat. So I can go ahead and read off some questions. But if someone wants to just jump in and come off the mic, it's a meeting. It's not set up as a webinar. So you feel free, to just come off the mic and jump in. But I'll start with the questions in the chat. That's okay. Did you have any other specific questions for Dr. Miraglia, Dr. Stewart?
I'm sure I'll think of some, but I want to give these guys a chance to.
Great. Okay. Well, Kathy wants to know, do you use RPEs? And if so, what types?
I do use, yes. So for children, I prefer RPE. And when we say RPE, I don't necessarily call it RPE. I do nothing rapid. So even in the kids, it's slow. So if I had to be exact, I'd say SPE, slow palatal expansion. However, what I'm using is fixed. In children and teens, I prefer fixed expansion appliances. We use upper and lower always, never just upper, and with an upper and a lower fixed expander and a slow technique for growth and development, you can have a significant amount of jaw growth and development in a short amount of time in a child and a teen. When you get to an adult, I prefer removable. So in the adult category, I prefer removable expansion appliances. And again, that's a slow pattern too, because you're looking to cycle your way through, bone growth and development. But RPE, not exactly perfect in the wording. I don't do anything rapid. I'm not interested in separating the two halves of the maxilla in 2 weeks.
And then a follow-up question, how often do you recommend turning?
So if we're talking about a child, so in the child category, which we'll call preteen, so anything from 6 to 12, the upper slow palatal expansion technique is 1 turn per day, as opposed to what would be considered rapid would be 3 turns a day. So depending upon the appliance, you might turn it once a day or every other day. A lower fixed expansion appliance in a child is going to be turned twice a week, maximum. And you get to the teens from 13 to 20. Fixed expanders from 13 to 20, those are only turned once or twice a week, depending upon how your patient feels. But that we spend a day teaching that. So I don't think tonight would qualify as running out tomorrow and making fixed expanders at the age of 17 and starting to try that on your own. That's mature bone. But can you use, and do we? Yes. And that's what we teach in our coursework is how do you use fixed expanders in a teenager and have that bone grow beautifully within a pattern that's totally comfortable. That's possible.
And can you comment on maxillary expansion if there are implants present?
Yeah, the less the better. In other words, the more teeth, the better. So in a perfect world, you've got a nice set of teeth you can play with, and with the teeth come the periodontal ligament, and with the teeth come flexibility, and you're mostly working with a cycle of pressure and tension to get sutural change and growth and a remodeling and reshaping of the maxilla. And a set of implants doesn't really offer as good a benefit, because once you've got a set of implants, you have something that's a bit rigid and it's not as easy, possible, but not as easy. So in our world, no implants would be the best case scenario. 1 in a quadrant is not so bad because you can relieve any pressure from it. It doesn't have to receive any pressure. And then you get your opportunity. And then all of a sudden, the more implants you have and the less teeth you have, you're just ratcheting up the risk. And then you have to pay closer attention to those patients to figure out, can you really do it with removable growth appliances, or did we miss our window for that patient?
Okay, great. And someone asked about specific growth and development removable appliances. I guess we can just touch on it that you're just using basically a 2-screw or a 3-screw. So
yeah, we can talk about, generically, basically you would talk about a base model being like an upper Schwartz or upper removable Schwartz appliance is like your generic base model type of growth appliance, and then a lower removable Schwartz. And if this is the adult category, that's where the removable appliances are being used. And then whether or not you add other components to it to, basically facilitate the type of diagnosis you have, whether you're dealing with class 1, 2, or 3, do you need anterior growth as well as wider? You could go from there. As far as fixed expanders go, I'm a big fan of the super screw. It's a type of mechanism. So the mechanism is a hexagonal threaded bar. And so I prefer it. It's easy. It comes with a wrench. So I'm a big fan of the super screw fixed expander. But in the kids, the lower is just a lower fixed Schwartz appliance. So it's not a mystery. Those have been around forever. Yeah.
okay. And what is the age of the oldest patient you have treated?
The oldest patient I've treated, 86.
And what was it, clear aligners or was it?
The 86 was clear aligners only. Yeah. So in the 80-year-old category, we've got quite a few 80-year-olds who do clear aligners. They happen to love it. So in the 80 category, 80 only clear aligners. I do not have a removable expansion appliance at the age of 80, nor would I probably be looking to do that at that age. Clear aligners can be effective enough to make a difference.
Great. That's all the questions in the chat. Does anyone want to come off mic, or I can ask some questions from the segment earlier? Is this a shy group, Dr. Stewart?
What?
Is this a shy group?
Yeah, they can be.
Okay.
There's usually a
And
few.
it's also late. It's late.
I see a few on here that
Okay.
that ask a lot of questions, but they're kind of being silent tonight. So I may have to start calling out people.
Well, I don't mind making
Sure.
a comment here.
Hi, Dr. Rice.
Hi there, everyone. So
Hello.
it's good to see everybody. And I have taken Dr. Miraglia's adult and pedo course, and I'm in Dr. Stewart's courses at the Stewart Center, and things just are dovetailing beautifully. So I just can't recommend both of these programs enough. It's really made a difference because I started out with a certain type of expander, and it's allowed me to really broaden my horizons and treatment options for patients, which is really what it's all about. So I'll say that and thank everyone. Thanks, Lauren, for putting this together.
Oh, it's my pleasure. And thanks for sharing. I appreciate
When
it.
Thank you, Kelly.
When you said you had an expander and it really broadened, I thought you were going to say you broadened your maxilla.
Well, actually, that would be true also.
You're a triple threat, Dr. Rice.
Uh-huh. Indeed.
So Ben, correct me if I'm wrong, but your typical adult patient, you're going to be doing some expansion and then probably finishing up with clear aligners, correct?
Yes. And so any adult that gets removable expansion, growth and development type appliances will have clear aligners second. I don't have any circumstance to describe having a removable expansion or growth and development style appliance first and not needing to coordinate the teeth. Because the moment you give the foundational growth, whatever they were connecting prior is going to be off. And that's okay. That's appropriate. Now that you've got the jaw growth and development, you start to coordinate your teeth. The important part is that part 2, when you're coordinating the teeth, has exactly the same philosophy and direction. You're wider and forward. You do not start to bring the teeth back together. So just because we grew wider and forward, and maybe there's a little spacing here and there, you don't close spaces. This is not a space closing technique. It is not a constricting technique. It is not a retractive technique. In part 2, when you're coordinating the teeth, the back teeth are going wider and the front teeth are going forward. So you're still giving growth and development in that direction. You just had your foundation first and your teeth second. Philosophy is the same.
Yeah. I believe we've got some questions coming in. Lauren, you want to read them?
Yeah, I'm going to take them.
Sure.
Under what kinds of circumstances do you recommend maxillofacial surgery?
Yes. So I've had 3 now in the last 5 years. So when a patient walks in and they're an adult and they have severe OSA, we'll say moderate to severe OSA, then you put together the credentials of your CBCT airway imaging and ENT nasal scope, and then of course your measurements and your diagnostics, and you start thinking about, wow, moderate to severe OSA, the list of medical conditions and symptoms and medications that comes with that history, the 2 or 3 decades that the patient might have already been suffering, and you start figuring out, does this patient belong in an MMA procedure? So I've had 3 people do that. One of them was 26, the other was about 30, and the next one was 52. All 3 of them were severe OSA. All of them have orthopedics and orthodontics on each side of the surgery. In other words, you don't just go for an MMA surgery. So you're pre-treated to get to MMA surgery, which means you're going to have removable expansion appliances, possibly brackets and wires, depending upon the condition, possibly clear aligners. But at the point you're ready for surgery, you go into surgery with a set of braces on because they need to get you connected with the elastics today. So the idea is we're going to pre-treat that patient for a number of months, set them up in brackets and wires so they can go into surgery. 12 weeks after surgery, the braces disappear and they go back into whatever the orthodontics are to coordinate the teeth. All 3 of those patients are now nasal breathers that are silent and invisible. They have no OSA. They have nothing other than nasal breathing, not even a snore, no airway resistance whatsoever. All the blood pressure medications are gone. All the extra weight is gone. All of the history, every single medical thing was cleared off of those 3 patients that we've put into MMA. And so it does become a process because you're going to be pre-treated, then MMA, then post-treated. So you could spend an amount of time doing that, but the biggest change comes with the MMA, because with the MMA, you go in there with a tiny airway and 6 hours later, you come out with a massive fire hose to breathe through. And those patients a day later have stabilization in their blood pressure, stabilization in their symptoms, elimination of, and the list goes on and on and on. And next thing you know, you've got a healthy patient that doesn't have a CPAP, that doesn't have an oxygen tank, that doesn't have symptoms, that doesn't have anything. So I am a big fan of MMA appropriately, and it would be in the category of moderate to severe OSA. We discuss it, and we've had 3 people choose it, and all of them very happy they did it. Best thing they ever did. Now, there are a lot of people in the moderate to severe OSA category that will decline MMA surgery. There's nothing wrong with declining something. The important part is that they learned that it's an option for them, because that is part of informed consent. And moderate to severe OSA patients are entitled and deserve a discussion about MMA. However, it should be with an oral surgery team that does MMA for OSA patients specifically. Because just because you can do MMA means nothing to me, because your patient has to come out with the appropriate amount of forward movement. Now, the hiccup is that if you follow traditional cephalometric tracings, you will not be moving the jaws forward enough, because traditional cephalometric tracings are based on smaller heads. When we had a lack of growth and development, and they put together this standard, but it was done off of children who were 5th generation post-industrial living. So they're not fully grown humans. So you have underdeveloped humans, and this tracing model was set up. So if you follow and go into an MMA surgery using traditional standards, you would only go forward a little bit, and you may not relieve the patient of the OSA. You basically have to kind of blow past traditional cephalometric standards in order to achieve a full airspace. So you need a good team to do that. So there's only, even though I've only done 3, there's only 2 groups I can work with. One is in California, that's Doctors Gunson and Arnett. They do a beautiful MMA surgery for OSA. And the other is Dr. Scotty Bolding. He operates out of, I believe he's in Tampa, St. Pete's Beach now. And he has some hospital affiliations in New Jersey. So he comes up and spends a week, a month in New Jersey now to help me out over there. So he's done 2 of them for me now. And Gunson and Arnett, those doctors did 1. Those 2 know how to pull that. And then next thing you know, you see all the schematics of the airway. And when the patient has no symptoms afterwards, you know you went far enough. So having the right team will be a benefit.
Did Scotty leave? He's not in Arkansas anymore?
He is probably still there. I don't think he relocated totally, but he's now doing some surgeries out of Tampa as well as New Jersey. So from Fayetteville to Tampa to New Jersey, and I forget the hospital, so I don't want to misspeak and say the wrong one, but he's available.
He's a classmate of mine in dental school, so I think a lot.
There you go. Oh, he does a beautiful surgery.
Yeah, awesome.
Could I ask a question that I hear from our alumni, from at least some of them? You know, that some of them have talked about treating airway and getting into it and a little bit hesitant to do that, one option out there is an organization that's doing primarily expansion and not finishing, or at least in the past they weren't, not really finishing patients and kind of leaving people wondering whether or not they really want to go down that road. Can you guys talk a little bit about, and the additional piece to that is most of our doctors, I think it's fair to say that they primarily treat adults. So if they're interested in treating adults and they want to start doing airway, what's the training commitment to get to the point where they're able to start treating, feeling confident treating airway patients?
Well, that would be our second day. In other words, we have a pediatric day set up, we have an adult day set up. And in the adult day, that's where you get your first 8 hours of training in how do you make appliances that can develop the foundation, but then how do you handle the teeth afterwards? Because if you only use removable type appliances in an adult and grow the foundation, then you're left with a bite that's weird and teeth that are awkward, but you may very well have solved an OSA issue or a slurring issue. And so that's nice, you made an improvement, but that's not where the case ends. Now you got to coordinate those teeth. So you're going to need a good clear aligner technique, because most adults don't want to wear braces. And brackets and wires are not easy to do in an expansive technique.
Right.
Basically,
I'm sorry.
Generally braces are retractive, so you would be careful with that. We're not trying to put people in braces. But if you learn a removable expansion appliance technique followed by a clear aligner technique, you could be well suited to then treat the entire patient. And then, it's about getting your records, making a diagnosis, having a nice consultation, figuring out what the patient is willing to do. And then, of course, what level of benefit can you bring them to? The bigger part of it is the mentorship afterwards. So when you go through an AHS day like that, we also offer follow-up, and that is in the form of mentorship, where I can help you review the cases and follow the treatment over time. And so basically you can kind of be attached. Lauren built a beautiful platform through Dropbox where it's all HIPAA protected, and you can upload case work histories, records. We can review them together and we exchange. Then, we work your way through the diagnostics, through the consultation, through the treatment. What are our options? What does the patient want to do? And then you get a variety in there of patients who are willing to do everything. Then some patients, so I don't want to go this way, I don't want to do that way. You're just trying to make it as good an improvement as you can, given the constraints upon what they might allow. Like anybody else, I have a lot of patients who I might love the idea of giving them removable expansion appliances, but they're not prepared to wear them for as long as it will take to deliver a compliance model that will grow the bone. They might choose aligners alone. It doesn't mean I can't treat the patient. I can now only make this amount of improvement for you. There are patients in the severe OSA category where maybe MMA is the best choice for them. But if they're not ready to pull the trigger and go through MMA surgery, well, we don't dismiss them as patients. What's our next best option? Removable appliances plus clear aligners. If they refuse removable appliances, what's our next best option? Clear aligners alone. You just need a technique that you can do in there. The biggest part about it is recognizing the nasal chamber and what the ENT might have to do to help in there, and the myofunctional therapy with Frenum revision work. Those added to the puzzle can make a big change. And then now you've got a toolbox that you can work with. And in the consultation, you figure out, this is what I have to offer and what are you willing to do? And then you come up with how you treat the patient. Same thing, you could think about dentistry also. There are patients who want to make a bridge. There are people who want to have an implant. There are people who don't want an implant. You make a bridge. If you don't want a bridge, you get a removable. There are different options.
So what I'm hearing is it's relatively quick between training and actually being able to jump in.
Yeah, surprisingly.
Yeah. Okay.
If I may add, just because I heard so much feedback, and Dr. Rice has been a client of ours, a member for a long time, is I always affectionately say that Dr. Miraglia is like the Mr. Rogers of Airway. You just have this wonderful way of making everything so logical, so simple, and so integratable that, when we said, can we do this in a day? The answer is yes, because we really simplify it. And that's the beauty of it, is that that's what makes it integratable, is the simplicity of it all.
Thank you.
Yeah. And, Kelly said earlier about the dovetailing. When I hear you talk, it's just like, I hear myself when I'm talking to other doctors or the patients. It's all about gaining the knowledge of what is optimally the best for that patient. and then telling them that, and then backtracking on, well, I don't want to do that. Okay, then here's what we can do for you. You know, MMA surgery. I see so many doctors that say, well, yeah, I gave him surgery as an option, but it's kind of like, yeah, well, surgery is an option, but you probably don't want to do that. You know, so that's not really giving them that option. But it's, you know, when you're faced with a patient that's really severe and you can give them hope, maybe then it leaves it in their decision, puts it in the ballpark where they can decide how they want to proceed. And maybe they want to expand and do clear liners. Maybe somewhere during expansion, they start feeling so well that they may change their mind. So that's my comments leading up to a question. Ben, I don't think I misheard you, but with your MMA surgery patients, you're still doing expansion prior to the surgery.
Yeah, they're pre-treated. Yeah, nobody goes into MMA with the underdeveloped jaws they have, because what they're going into MMA for is mostly forward growth.
Yes.
You're not going to take them from 27 millimeters wide to 40 with MMA. So you need to give them this first. And so it's much better to develop the width as best you can, which usually gives you some forward. So you're pre-treating that patient to get into the MMA, and then you can coordinate teeth second. So, you know, we get them through removable expansion appliances if they're willing, and or clear aligners to get it all set up. And then I will be putting their brackets and wires on a week before surgery. Brackets go in, wire goes on, go into surgery, see me 12 weeks later, all that disappears. And we go back to either the expansion appliances if we still needed more, or clear aligners to coordinate them. And yeah, no one in the dental profession should say you don't want surgery. And I'll tell you why, because the 3 people that we offered the MMA and guided them towards it, it was intentional, because it took away CPAP machines. It took away uncontrolled blood pressure. You know, the 52-year-old who was an athlete, a 52-year-old physical specimen athlete, couldn't sleep more than an hour and a half at a time and had wildly uncontrollable blood pressure for 10 years. So for 10 years, having wildly uncontrollable blood pressure, can't sleep for more than an hour and a half. You know, this is a guy who, even though you're a physical specimen, you're well on your way to having your heart attack is what you're going to do. And of course, his history was 4 bicuspid extraction, retraction. He had nothing to breathe through whatsoever. Everything, he was underdeveloped as a child, and then he was treated with a subtractive technique. So it made him worse. So we talked to him about, this is your pathway to optimal health, because I can only deliver so much given where you are. So we, not only did we treat him, but one day after surgery, he was breathing through his nose only, and his blood pressure stabilized. And he was, within 2 weeks, he was off the blood pressure medication. This is going back 5 years. He's 5 years post-surgical date. And he hasn't taken a single blood pressure medication. He has his own cuff at home. He used to have the full professional cuff at home because he would take his blood pressure every so many hours to monitor and talk with his cardiologist about his condition. Meanwhile, now he's 5 years later, and he stopped going to the cardiologist 4 years ago because the cardiologist said, you don't have to come to me anymore. You're all done. You don't have a blood pressure issue anymore. So he has a perfectly normal blood pressure, has no medications for all these years. And the crazy thing about it is, this guy comes in, he gets his teeth cleaned, and every time he gets his teeth cleaned, he leaves saying, I just can't believe it, but you're the one who saved my life. Of all the specialty and all the people I saw and who's been monitoring and checking for 10 years my blood pressure problem, and the dentist fixed my problem. You saved my life. And that's what I get to hear. That's because of the MMA surgery. I was not going to be able to do that with clear aligners alone. I was not going to be able to get him that far with removable expanders and then clear aligners. There was no combination outside of the MMA. And this guy's going to have a different future because of that surgery. And it's the same for the other 2 who went into it also. I couldn't get that big enough difference alone, but the MMA was the answer for them. You just have to move appropriately, meaning enough forward.
Right. And there's a question here, is how often are you needing to restore the VDO following expansion?
Very rarely, but the teeth need restorations, but I almost never increase a VDO with restorative dentistry after growth and development first. So it turns out when you deliver all of your growth and development and you upright all of the back teeth, you get a change in the VDO. People who are underdeveloped have lower teeth leaning in. And when those teeth are eventually upright, you're doing relative extrusion. That's a raising, so to speak, of the lower occlusal plane. posterior relative extrusion is wonderful. That's the lower teeth. But the upper teeth are angled like this. And when they're upright, you have relative extrusion as well. Well, when you give relative extrusion to all of the back teeth, you get a significant change in the VDO, and a deep bite disappears through all of the posterior elevation. So following removable expansion and or clear aligner technique with relative extrusion of the posterior uprighting, very rarely do I need to then increase it with restorative dentistry. It's usually then restoring the anatomy, but without changing the VDO.
So I briefly, when we met a couple of months ago, Ben, and I had a meeting with Lauren, I told you briefly about what we teach. And our restorative technique is, we're not saying you can't restore in porcelain with crowns, but we specialize in teaching our doctors a very conservative, minimally or non-invasive way. So I've been doing expansion enough now that I've had several patients that we put through expansion, some clear aligners, and then restored. And he's exactly right. Ben's exactly right. The vertical dimension increases naturally when you upright the teeth. You might need to open it to get the anatomy in, but you're not increasing. You're not doing a major increase by adding length to the teeth because you've done that effectively by uprighting. And it really does make for a very predictable and stable occlusal scheme. And the restorative part is just as significant as what we've been doing before we started this expansion. We're just not using as much composite. But what composite we are using does make a big difference. So what this does in a nutshell, when you expand and when you upright the teeth, is it makes the restorative part on these adults with severely worn down teeth, it makes it much easier and a lot more fun and not nearly as frustrating.
Oh yeah, you don't have to prepare teeth that are lingually inclined.
Yeah.
On a patient who has a 27 millimeter transverse measurement, who wants to prep teeth that are leaning in like this? And you cannot restore teeth to vertical occlusion when you're leaning like this. Lingual inclination cannot be solved restoratively. So you upright first, then you restore second. Now you've got your beautiful occlusion back. So you basically facilitate a better restorative result by positioning the foundation in the teeth first, and then you go ahead and do the restorative second. So we do a fair amount of restorative dentistry. We just don't take, a deep bite where you can't see the bottom teeth and open them 5 or 6 millimeters with restorations anymore. First, it's develop all the jaws, and then that reduces itself down to very little. And you may be adding a millimeter and a half, but that's more like you were mentioning, where you're giving back the incisal and the cuspal anatomy, and now you've got your full completion of the result. I was really speaking about just, are we looking to add 4, 5, 6 millimeters of opening to someone who is overclosed? I'd rather be doing it in the growth department first, and then whatever residual is left in the restorative work, which in our world is then under 2 millimeters and sometimes only like 1.
Ben, could you, one of our doctors, Pam Wilson, was asking, you don't have to go into details, but I could see where, traditionally we think of cephalometric measurements to know where to move things in MMA surgery. And I agree with you 100%. We don't use that. We use Sassoon measurements. But what are you doing as far as your measurements with your surgeons? Obviously, they're making the measurements and knowing how far to move the jaw forward. What method are they using?
Yeah, so I'm not opposed to Sassoon Plus, but the beauty of the digital surgical software now is that because you can have the area and volume of that airway on the screen, it's almost like we do with if you're thinking about our clear aligner world, you know how you have your digital model of the teeth and it plays through the movement?
Yeah.
Well, now the oral surgery programs have the digital model of the jaw structure moving, and you can pre-watch the surgery on the screen. And what it does is it shows the amount of movement of the jaws so that you can see what the area and volume will be. And from that position, they make their plates because those are all fabricated prior to surgery. So in fact, Dr. Bowling, some of those are 3D printed. Those are made right there for him. So they come out of the machine. He goes into surgery. He knows the distance he has to travel and the plate fits. He puts it together. So you're almost watching a clean check of the jaw movement, and it produces the area and volume you'd like to see at the end, because we already know what area and volume delivers a nasal breather. So when you have an appropriate area and volume, if you're familiar with the CBCT color coding, you know how it starts out, if the best category is white and then blue, and then you get to, all of a sudden you go from yellow to orange to red to black is nothing. Well, that it should be white and blue. You should be white and blue throughout, and you've got a fire hose to breathe through. Well, the surgical software can pull the jaws forward to deliver white or blue. So now once you're above that certain, 250, cc mark, all of a sudden you've got a beautiful airspace. The surgery now has the map of the distance you'll move, and it prints out the plates that you would put to fasten the bone at that point. He knows exactly where to put the jaw. And what it will be is ahead of traditional cephalometrics. In other words, if you develop the airspace and then set the jaw to beautiful breathing, you will be ahead of traditional cephalometrics, because traditional cephalometrics are not for full-grown human being numbers. Those were all developed in the 60s and 70s by people taking cephs of kids and teens who were underdeveloped human beings. They're not a norm. They're a standard for underdeveloped jaws. So if you wanted to have a cephalometric tracing that was a norm, you'd have to go 400 years ago, prior to industrial Western living, where you had fully developed jaws at each age to then record and then lay over a traditional human being today and show everybody's underdeveloped and too small. Everything should be wider and forward. So that software is beautiful. And so now you know where to take a human being. Yeah. You're not going ahead of normal human growth and development, by the way. In other words, you're not taking someone's jaw past where they belong. You're bringing them where they should have been had they grown fully and had 32 teeth. That's an end result. So just to have the right perspective, we're not trying to make someone non-human. You're just bringing them to where a human being should be and used to be prior to an early soft diet.
Then we have another question about your preferred method for taking a construction bite for your removable adult expansion appliances.
Yes, so it's interesting because it's not about the teeth, so it doesn't matter. The bite has no effect on making a removable expansion appliance. You can send in a set of scanned models in MIP because you're growing the bone. You're not focusing on the teeth. It makes no difference where the teeth connect. At the beginning of treatment, where the teeth are connecting is completely inappropriate and wrong. So that will not be how they're connecting at the end of treatment. So we're not basing any design and or initial movement based on the tooth or teeth as they're connecting at the beginning of treatment. I send in MIP, develop an appliance, and then we're going to grow the jaws. The bite's going to feel weird, and then we're going to coordinate the teeth, and we're going to have a beautiful occlusion like you just watched in 3 little examples. But the idea is none of it is about the original malocclusion. That original position is part of the disaster, why the child has, or the teen or the adult has the list of symptoms that they have. So the last thing we're doing is basing anything off of the teeth at the beginning. All we know about the teeth at the beginning is none of them are correct. We need a foundation relocated, then we need the teeth coordinated. And that's why the photographs of the befores and afters of the 3 patients you saw are so drastically different, from their teeth to their smile, to their face, to their profile. That's a huge change in those 3 people. And that's the standard across all of the kids and adults and teens we treat, because you're relocating a foundation and the teeth second. You have people who look different, and what they look is better or more normally grown and developed type of human characteristics. Yeah, don't get caught up on the teeth at the beginning.
Yeah.
It's a pitfall.
Will expansion improve an anterior open bite class 2?
Class 2 anterior open bite. Well, expansion only won't, but I can tell you what will. Nasal hygiene, myofunctional therapy, Frenum revision. When you say anterior open bite, class 2, I hear that patient probably needs 5 different Frenum revised with a year of myofunctional therapy, as well as expansion appliances in the removable or fixed category, depending upon the age we're talking about, followed by either brackets and wires or clear aligners, depending upon what age we're talking about. There's a fair chance that patient has a deviated septum that'll need attention. There's a fair chance that patient can't breathe through their nose at all. So that's going to need attention. So we have a long list of things. An expander alone is never the answer. It's always a long list of things to address to get that description correct. Because when I hear class 2 open anterior bite, you're going to have significant overjet. You're describing to me a patient who is almost by now an obligate mouth breather. And if that patient is now an obligate mouth breather, you have a long way to go to get that patient right. And an expander will be part of a long list of things we're going to do to solve and heal that patient. Yeah, one piece of the puzzle.
And it sounds like the expansion appliances disarticulate the teeth during the therapeutic process. Is that correct?
Sure. Yeah. If we're using removable expansion appliances and we're in the adult category, they come with a occlusal pad on the upper one. So you have an open, so to speak, bite while you're working the foundation. And the patient knows, yeah, it feels weird when I bite, but they're totally comfortable and easy to use. The lower one, we do not make the occlusal pad on. It just tucks in the lingual of the teeth and along the alveolar ridge. If we're talking about kids with fixed expanders, we apply the fixed expanders. And then what we do is we teach a technique to just flow either the orthodontic cement that you're using to cement the bands into the occlusion to kind of level off the tooth to produce it's almost like doing a buildup, a posterior buildup. You're basically seating the fixed expander and allowing the cement to fill in the occlusion. It's like a super sealant. I call it a super sealant, where you let the cement flow over the top of the tooth. And by the time you've put on your two expanders and you have the occlusion kind of filled in of those teeth, when the patient bites down and starts to open the bite, so you have disclusion, a little bit of unlocking of that terrible collapsed bite you're working on. So yeah, in any direction you're going, you're unlocking the patient a little bit.
And I'm just going to redress one of the questions. It's about the different training programs out there. How does your training program differ from others? I know what your answer is going to be, but I'm going to have you answer this.
Yeah. So, and there are different places to learn, of course, and I've been to most of them. And so I have been to most of them. I have taught for most of them. I have taken pieces from some of them. The idea is that you can never learn too much. So I would never discourage anybody from learning somewhere else, because you can learn from anybody, and then you can figure out, is that something I liked all of it? Did I like some of it? Did I like a piece of it? Did I like, so learning more never hurt anybody. Then how much you then take back and use, what are you comfortable with? There are preferences. I definitely feel like with the last 18 years of doing what I'm doing, I have worked out a lot of kinks. So what I can almost guarantee is that I have tried so many different things over so long a time and then gathered so many pieces along the way. I basically pulled my favorite pieces that work really well. And when you put it all together and you have a certain kind of preference and or technique that can show results and healing of a human being, not just fixing a bite, but healing of a human being, well, now I feel like my technique is pretty solid, and then I'd like to share it. And then the idea is you can take my coursework, and then in the end, you don't have to be a disciple of mine. You can pick and choose. And maybe you like a certain style fixed expander that we make on kids, or maybe you prefer another one. I know there are 20 different fixed expanders you can make for children. I've tried most of them. Removable expansion or growth appliances. There's a whole line of those. You can try different things and figure out, do you have a preference? Do you like working with one or the other? Is one of them more technique sensitive than another? Is one of them more forgiving than another? So the idea is, thanks to having a lot of troubleshooting over the years and figuring out by taking a lot of different programs in different directions, I feel like I boiled it down to a really nice technique that offers the maximum amount of healing in a human being with the least amount of complexity. I'm not looking to overcomplicate anything, and I'd like to have the simplest process to deliver the healthiest patient possible. That's kind of how I work.
That's exactly what I was going to say.
There you go.
I was going to say something similar, maybe not exactly that way, but what Ben does is he takes all those years of experience and streamlines it, and without watering it down. There's no water down, but he throws the chaff away and just keeps the wheat and shares it. And if it's a 2-day course, you don't want to blink, because everything he says is succinct, it's important, and you get it, kind of fed through a fire hose, but very clearly explained. I told Ben, and I still feel this way, the first time I heard him lecture, he lectured for 8 hours on pediatric dentistry, not pediatric, pediatric expansion. I told him it was the best 8-hour lecture I've ever heard. It was amazing. Just the information was incredible. So you've got a gifted teacher with an incredible amount of experience that's preaching a very, very important, life-changing, life-saving message. So as far as I'm concerned, how Ben differs is he gives you tools that you literally can go back on Monday and start, you're going to see things different. Like you all did. We get this all the time. They come to the Stewart Center the first weekend, they go back home and they go, I can never see occlusion and dentistry again the same because of what I've learned. That's what you get with Ben. So there's not a lot of bureaucracy either, which can be an issue with some of these companies.
And that's
There's
one thing about
there's
the
no
program.
bureaucracy.
Yeah,
Yeah, zero.
zero, zero bureaucracy. No to bureaucracy.
Yeah, we're trying to help people, not kill them.
We are extending a special promotion, and we just don't discount. We don't. I know Dr. Rice knows this, but we really we're so appreciative of this opportunity to share our information with you and to learn more. That we are extending a 10% courtesy to our mini residency. I am going to just send you a link, and the easiest way would be to sign up, because actually January is almost full. I know, Dr. Stewart, you're going to be joining us, but that's why I'm just going to send you the link to register and email info@airwayhealthsolutions.com. Just email us that you're the Stewart Center alumni, and we'll refund your credit card 10%. I think that's just the cleanest way to do it. And then this way you can pick whatever course and date works well for you. But we're happy to do that. And we really hope that we have more airway dentists to help more people. Those green dots that you saw earlier, if you were on before, I can't tell you how many people I can probably send to you, especially if there's anyone in Florida, there seems to be, or the Midwest. I don't know if there's anyone out there in particular, but I get a lot of requests from consumers, patients looking for airway dentists. So we'd love to get more people on the airway locator. I think there was just a question about the nasal breathing protocol that we missed, and
Okay.
also phase 1, phase 2, but we do go over this in detail in the mini residency. It's not just a simple answer, it's a protocol, and that's why we developed this program. So maybe we should table that since it's 10 o'clock, and I know everyone's probably tired.
Yeah, we have an entire section on nasal hygiene and what are
Yeah,
the different
it's
things you can do
it's not a
to.
short answer, really.
Yeah.
Well, I just want to say thank you. You guys are amazing. Really a worthwhile night spent. So thanks again for doing this.
You're welcome. Thank you.
Yeah, Lauren, Ben, we really do appreciate it. Thank you so much. We're
Thank
so
you.
excited to be.
My pleasure.
We're excited to be in collaboration with you guys. We are, like, again, Kelly said, it's a dovetail, and I think that what you're doing is making the world a better place for patients by training dentists, and I like to think that we're doing that too. So that's where I was just attracted like a magnet to your organization. And
Yeah, we're gonna play well in the sandbox together.
yeah.
And save a lot of lives. So thank you, everyone, for your passion and your commitment and for having us.
All right.
Take
Good
care.
night.
Good night.
Good night, everybody.
Guys. Good seeing
Thank you very
everybody.
much. Good
All right.
night. Take care,
Thank
Hal.
you. Take care.